How's it going, guys? Past level question, Repro, step 1, Obscan 2CK, 34-year-old woman, 1-year history of difficulty conceiving with her husband. Her husband has 2 children from a prior marriage. BMI 32. Menses occur at irregular 14 and 37-day intervals. Physical exam shows acne on the face, upper back. Question wants to know which of the following most likely we see in this patient. So this is a very easy past level diagnosis of polycystic ovarian syndrome, which is when you have an overweight female who has irregular menses and hirsutism, okay? It's the same thing as anovulation. You'll hear these terms interchangeably. So anovulation refers to the process in which the woman is not going to be ovulating every cycle. If you merely add hirsutism on top of that, we call that PCOS, okay? So I'll explain that more specifically as we move through. So what are we going to see in this patient? Choice A, atrophy of endometrium, wrong fucking answer. This is what we would see with menopause. In polycystic ovarian syndrome, in contrast, you would have hyperplasia of the endometrium. So what's going to happen is high BMI causes insulin resistance, which leads to abnormal GnRH pulsation, which leads to increased LH to FSH ratio. It's an up arrow for LH and a down arrow for FSH, okay? Some students think that they're both up arrows. It's just that the ratio is increased. It's fucking wrong, okay? It's a down arrow for FSH, up arrow for LH. Now, what does LH normally do? It acts on the theca interna cells in females and the Leydig cells in males to make androgens. Well, if your LH is high, that explains why we have hirsutism here, because we have more androgen production. If FSH is low, we're going to have poor follicular development, which means that we're not going to get a Graafian follicle that ruptures, which means we're not going to get a corpus luteum. The fact that we don't get a ruptured follicle, it's going to be retained as a cyst. And when this occurs over many cycles, holy shit, polycystic ovarian syndrome. But the corpus luteum aspect, it's the structure that it's the name for the ruptured follicle, and it's going to secrete progesterone. One of the roles of progesterone, not just to maintain the pregnancy if it occurs, but is also to limit the growth of endometrium. In contrast, estrogen stimulates growth of endometrium. So if we don't ovulate and we don't get a corpus luteum and we don't get progesterone production, we're going to have what's called unopposed estrogen, which is going to lead to endometrial hyperplasia and increased risk of endometrial cancer later. So let's just look at the other answers here. Choice B, decreased LH, wrong fucking answer. As I just said, LH is going to be high in the setting of anovulation / PCOS. And we said insulin resistance causing abnormal GnRH pulsation is the mechanism. In contrast, LH is decreased as well as FSH, both down arrows, if we had anorexia causing abnormal GnRH pulsation, okay? It's a bit of an annoying mechanism if we want to get nitpicky about it, which USMLE won't, truthfully. But in anorexia, they are going to have decreased leptin levels because leptin makes you feel full. So if you're anorexic, you're going to be hungry. So they have decreased leptin levels. Leptin is normal basal leptin levels are required for normal GnRH pulsation. So in anorexia, abnormal GnRH pulsation, and they're going to get decreased LH and decreased FSH. I don't want you to associate insulin resistance and obesity with PCOS with leptin, okay? It's not related. Don't overlap leptin explanation with PCOS. It's just for anorexia. Point is, wrong fucking answer. Choice C, endometrioma is wrong fucking answer. This refers to chocolate cysts that you get with endometriosis, which rather than abnormal periods in terms of irregular menses, we're going to have dysmenorrhea, which is just painful periods, okay? So I've made many clips on this, talked about this in PDFs, but endometriosis is going to be a woman over the age of 20 who has painful periods and an abnormal physical exam. You cannot rely on dyspareunia, which is pain during sex, and pain with defecation as buzzy crutches for endometriosis. You're not going to see those in the majority of vignettes. So they'll just give you painful periods, woman over 20, and something abnormal in the physical exam, such as nodularity of the uterosacral ligaments. Okay, they could say retroflexed uterus with nodularity. Doesn't matter. Just any abnormality, that's going to be endometriosis. But endometriosis refers to endometrial tissue growing outside the myometrium, classically on the ovaries, and it's going to bleed with menses, leading to what are called chocolate cysts or endometriomas. You're going to do diagnostic laparoscopy as first step for 2CK. Choice C, wrong fucking answer. Choice D, prostaglandin hypersecretion, wrong fucking answer. This is going to refer to primary dysmenorrhea, which is going to be a woman who has painful periods and a normal physical exam, okay? Especially if she's under 20. So if you get painful periods under 20, it's primary dysmenorrhea, just prostaglandin hypersecretion, PGF2 alpha hypersecretion. And it's just, you got to know that that's the most common cause of painful periods. If you get a woman over 20 and you think, oh, it could be endometriosis, they tell you the physical exam is normal, that's going to be primary dysmenorrhea as well. Choice D, wrong fucking answer. Choice C, reduced luteal progesterone, correct answer. So as I just mentioned before, for polycystic ovarian syndrome / anovulation, you are going to not have formation of a corpus luteum because the decreased FSH is not going to allow a Graafian follicle to rupture. Without the corpus luteum, we're not going to have progesterone secretion. And as I already harped on, it's going to lead to unopposed estrogen, endometrial hyperplasia, increased risk of endometrial adenocarcinoma later in life. Correct answer. You know the deal. I'm going to make more content. If you like my stuff, subscribe to my channel. Appreciate your time. That's it.